This data visualization compares two clinical presentations. Patient A arrives with a blood pressure of 210 over 115 millimeters of mercury, but feels entirely fine. Patient B presents with a lower reading of 175 over 110, but is experiencing confusion, visual disturbances, and papilledema, a threat. A true hypertensive emergency is defined by a elite. Asymptomatic severe hypertension is simply uncontrolled chronic hypertension. Grounded, serious protocols based solely on surpassing a specific blood pressure threshold lead to unnecessary hospital admissions for stable patients, while potentially delaying critical care for patients exhibiting lower numbers but active tissue damage. When presented with severe hypertension, the immediate clinical reflex is often to aggressively drop the pressure to normal. Applying that reflex to a chronically hypertensive patient frequently causes fatal iatrogenic complications. To understand why rapid correction induces mortality rather than preventing it, we have to analyze the self-perpetuating pathophysiology of the crisis. The initial trigger for a hypertensive crisis is an abrupt rise in systemic vascular resistance that overwhelms the endothelium's compensatory vasodilatory responses. This ESC flowchart maps to cascade. Severe hypertension fractures regulatory systems, forcing pressure-induced natriuresis. This volume depletion activates the renin-angiotensin system. Simultaneously, escalating vascular resistance and autoregulation failure cause microcirculatory damage. This forms a biological loop, driving further renin-angiotensin activation and higher vascular resistance. The physical consequences of this cycle include platelet activation, fibrin deposition, and ultimately fibrinoid necrosis of the arterioles. With the vessels necrotic and self-regulation destroyed, the patient's prothrombotic status spikes, exposing them to both massive ischemic organ hypoperfusion and severe hemorrhagic complications. This graph plots cerebral blood flow against mean arterial pressure. Healthy autoregulation maintains constant flow, forming a steady plateau. In chronic hypertension, vessels adapt, shifting the curve right. Rapidly forcing pressure down to a normal 120 over 80 pushes the patient off their adapted curve. The brain is suddenly starved of blood. This cerebral hypoperfusion causes ischemic stroke, while similar mechanisms in the coronary arteries trigger acute myocardial infarction. For the chronic hypertensive patient, acute normotension is lethal. The standard therapeutic goal is a controlled reduction of mean arterial pressure by no more than 20 to 25% within the first hour. This matrix outlines how treatment choice is strictly dictated by the specific target organ sustaining damage, rather than the absolute blood pressure reading. In neurologic emergencies, such as hypertensive encephalopathy, where cerebral edema is actively developing, short-acting titratable agents like nicardipine or labetalol are required. Sodium nitroprusside is contraindicated because it can increase intracranial pressure. In other emergencies, nitroprusside functions as a highly potent venous and arterial dilator, exerting an instantaneous effect lasting only 2 to 3 minutes. However, its metabolism relies on nitric oxide and cyanide. Prolonged infusions or administration in patients with renal dysfunction carry a high risk of cyanide toxicity. Obstetric emergencies, like eclampsia, present different parameters. The target systolic pressure must be reduced below 140 within the first hour, using labetalol, hydralazine, or nicardipine. Because of fetal toxicity, ACE inhibitors and nitroprusside are strictly forbidden. Effective management pairs the pharmacological mechanics of the intravenous agent with the precise hemodynamic tolerances of the failing organ. This clinical algorithm standardizes triage for any patient presenting with a blood pressure exceeding 180 over 120. Step 1 requires immediate diagnostic assessment for hypertension-mediated organ damage, utilizing an ECG, a thorough neurological examination, and fundoscopy. If no organ damage is present, the diagnosis is severe uncontrolled hypertension. The patient requires adjustments to their oral antihypertensive regimen and subsequent outpatient follow-up, not critical care admission. If active organ damage is verified, the diagnosis becomes a true hypertensive emergency. This mandates immediate admission to a monitored intensive care unit and the initiation of specific titratable intravenous therapies. Even in the intensive care unit, the goal remains a measured 25% reduction in mean arterial pressure over the first hour, avoiding precipitous drops that compromise adapted autoregulation. This structured approach eliminates reactive overtreatment, prevents iatrogenic hypoperfusion, and concentrates clinical resources entirely on patients facing active physiological collapse. Hypertensive emergencies are defined strictly by tissue-level necrosis and organ failure, not by the height of a single blood pressure reading. Years of chronic hypertension force the body's vascular network to adapt, meaning a rapid return to medically standard blood pressure will actively starve the brain and heart of oxygen. Precision management demands halting the vicious cycle of microvascular injury through carefully controlled, condition-specific intravenous titration. Clinical success does not come from correcting a monitor's numbers. It comes from protecting the patient's organs from both the crisis and the cure.